Uh, Good morning. Today we will discuss prophylactic coagulation correction before invasive procedures in cirrhosis. So the key word here is prophylactic. That means the patient is not yet bleeding. So this we should keep in mind. This will be the outline. First we'll discuss normal coagulation cascade, then laboratory testing for the assessment of coagulation. Then we'll see how the hemostasis is balanced in cirrhotics and what are the destabilizing factors which can lead to disbalance in patients with cirrhosis, and what should we do prior to invasive procedures when we have to give prophylactic correction, whether we should give or not give, and in what conditions we should be giving. So basically hemostasis has four major events. First is primary hemostasis, which leads to initial platelet plug formation, and here we have three steps: platelet adhesion, activation and aggregation. Next step is secondary hemostasis, in which coagulation factors are activated and thrombin is generation. Again there are three basic steps: initiation, amplification and propagation. Now after thrombin is generated, then fibrin clot is formed and it is stabilized, and after that inhibition starts so that there is no excessive coagulation. So these steps are inhibition of thrombin generation and then fibrin clot lysis, that is fibrinolysis. So first of all, let's see primary hemostasis. The first step is there is a injury to the vessel wall, then vasoconstriction occurs, then exposure of the subendothelial collagen, then with these two receptors, von Willebrand factor and glycoprotein 1b/9, platelets adhere to the injured surface and the collagen. Then next is platelet activation. So what happens in platelet activation? There is a change in shape of the platelets, and then cytoplasmic granules are released. Here we can see that the thrombin which is generated in the secondary hemostasis, this again acts on the platelet itself and it helps in platelet activation. So primary and secondary hemostasis are not separated or independent of each other. They interact with each other at various steps. For example, thrombin in this step. So thrombin helps in platelet activation by protease activation receptors 1 and 4, and then the release of various types of granules, of which ADP is a very important, because ADP then binds to P2Y1 and P2Y12 receptors which are present on the platelet, and also thromboxane, which enhances vasoconstriction and platelet aggregation. Then these granules are released, and there are various types of granules which have various functions. Now next is platelet aggregation. Platelet aggregation. So after activation, what happens? Platelets aggregate with each other by cross-linking with fibrinogen and glycoprotein 2b/3a receptors. So adhesion, then activation, and then aggregation. These are the three steps of primary hemostasis. Then secondary hemostasis, again three steps: initiation, amplification and propagation. Initiation can be from intrinsic pathway, which is minor, and it can be from the extrinsic pathway. Intrinsic pathway is started by contact factors, whereas extrinsic pathway by trauma. That ultimately these, then amplification occurs, then propagation occurs through various steps. Ultimately the purpose is to formation of thrombin. From prothrombin to thrombin, this occurs. And then as we have seen, thrombin acts on platelets which get activated, and activated platelets in turn provide surface for secondary hemostasis. They increase the negatively charged phosphatidyl serine on the platelet surface, so binding site for the coagulation proteins. They release various factors from the alpha granules, and they express receptors for other coagulation factors on the surface. So primary hemostasis is feeding into the secondary, secondary is feeding into the primary. So there is a balance going on. Next step is clot formation and stabilization. So thrombin has been formed. Now it will convert fibrinogen to soluble fibrin, and few clotting factors are involved, and then insoluble cross-linked fibrin will be formed. Now, once fibrin has been formed, then there has to be some check and balances so that excessive thrombin generation is not there. So inhibition of coagulation occurs. Thrombin is combined with thrombomodulin, and when thrombomodulin gets combined with thrombin, thrombin becomes inactive and it can no longer activate the procoagulant factors or protein C. So thrombin plus thrombomodulin leads to activation of protein C and protein S, and these proteins are in turn inhibitory to various steps in the secondary process. And also antithrombin 3 directly inhibits thrombin and few steps in the coagulation cascade. Then fibrinolysis is going to occur. We have insoluble cross-linked fibrins, then this degradation occurs, then fibrin degradation products are formed, and D-dimer is the smallest fibrin degradation product. It occurs by plasmin, which in turn is formed from plasminogen by tissue plasminogen activator, which in turn are inhibited by these two factors, plasminogen activation inhibitors and thrombin activator fibrinolysis inhibitor. Now, at this step also platelets are very important. Again, primary and secondary hemostasis are feeding into each other. There is an anti-fibrinolytic role for platelets by activation of these two inhibitors, and there is a clot retraction of fibrin network also, and there is also a pro-fibrinolytic role of platelets also. They provide surface for activated platelet bind coagulation factors, fibrinogen, collagen, etc. And then they retain plasminogen on the membranes, which leads to formation of plasmin. So both anti and pro-fibrinolytic role of primary hemostatic factors here. Now we have to be cautious that there is a role of activated neutrophils and RBCs also on coagulation, especially platelets. Wherever there are activated neutrophils, they induce platelet activation and aggregation, and through the release of neutrophil extracellular traps, they can provide scaffolds for platelet, RBCs, tissue factor and wall bilirubin factor. Similarly, RBCs, through various mechanisms, they ultimately lead to platelet aggregation. So this is a well-known fact that when RBCs are low, platelet functions are also problematic, as in well known in CKD patients. It can also be possible in cirrhosis patients also. Now, how do we assess coagulation? So this is the outline of various methods for assessing coagulation factors. Conventionally, we have PT-INR, platelet count, bleeding time. We can assess the fibrinogen or fibrinolytic pathway by thrombin time, fibrinogen, D-dimer, fibrin degradation products. Then we have viscoelastic tests, which are in vogue these days, which is TAG, ROTEM and sonoclot. Then we have thrombin generation assays, which are considered to be gold standard, which can be done with and without thrombomodulin. Then there are platelet functionality assays, platelet function tests. There are various methods we will see. Then we can assess individual factor levels also, von Willebrand factor, factor 2 and other factors. Now we all know that there are problems with PT-INR in cirrhosis because these are only responsive to procoagulant factors. PT measures fibrin formation. Whenever plasma starts to clot, it will stop measuring at this level, and this step is reached with as little as only 5% of the thrombin generation, whereas the 95% of the thrombin generation remains undetected by this test. And also time is not sufficient from thrombin to activate protein C. This is the last step. So in the initial 5%, this step is not going to come. And tests are also performed without added thrombomodulin so that full activation of protein C not occur. Activated protein C is not reflected in this test, and we know that protein C in cirrhosis plasma is decreased. So these tests will not reflect the balance between pro and anticoagulant factors that is characteristic of cirrhosis patients. Now, viscoelastic test, TAG, ROTEM, sonoclot. So we have seen that standard tests stop measuring at the first stage of coagulation when the clot is first forming, whereas viscoelastic tests measure the whole of the process. Standard tests are done in platelet poor plasma. So PT-INR is actually measuring plasma hemostasis, not what is actually happening in the patient. It is not measuring the patient hemostasis, because VETs are done in whole blood, PT-APT in platelet poor plasma. Now 3 VETs, there are many more, but these 3 we have with us at ILBS. TAG is there, ROTEM is there, and Sonoclot is there. These 2 are rotation based systems. There is rotating cup and needle type of thing, which and then when clot formation occurs, the viscosity increases and it is detected. Whereas Sonoclot is a linear motion, not rotational but linear. All 3 tests are done in whole blood. Assay time varies 15 to 20 minutes, 5 to 10 minutes, and up to 30 minutes. In ROTEM and TAG, there are various activators and functionalities are available. If you look at the ROTEM, there are XTEM, FIPTEM, APTEM, INTEM. These are the commonly used, but there are many others also, HAPTEM, NAPTEM, ICATEM, etc. Now, ROTEM platelet functionality assays have also been incorporated in the newer versions, which can measure some amount of platelet functionality. Similarly with TAG, conventional TAG and functional TAG, and TAG platelet mapping has also been introduced in newer versions. These are the TAG and ROTEM comparable parameters. So basically it is the in TAG R, then alpha angle, maximum amplitude, and clot lysis. Similarly here it is clotting type, clot functional time, alpha angle, again MCF, and lysis time. This is sensitive to platelet count, but no information is gathered regarding the function or primary hemostasis, although newer machines have some amount of platelet mapping, but it is not up to the date. Now this is Sonoclot signature. Here we can also measure the platelet function by the R3 gradient, whereas the others are activated clotting time, clot rate, then this is the peak amplitude, that is the time to peak. So these all things mean different things. R3 is the platelet function, R2 that is the peak amplitude, it is the index of fibrin concentration, R2 is the index of rate of conversion of fibrinogen to fibrin, so on and so forth. Now these are the various platelet functionality assays. So we have to remember there are no laboratory tests that can assess vessel wall or endothelial cells. These have been the classically bleeding time, which is not useful and no longer used. Then we have PFA, LTA. So the gold standard is light transmission aggregometer. This is done in the citrate platelet plasma, all others in the whole blood. This is the reference standard, but actually it is non-physiological because it does not include the whole blood component, and what is actually happening in the body, it only gives non-physiological measure. Then there are others, impedance aggregometry, viscoelastic tests we have discussed. Then there is flow cytometry, we can measure what receptors are activated on the platelets and we can see. Then there is soluble activation markers, that is when platelets get activated they release various markers in the blood, then these can also be measured. Light transmission aggregometer has recently been procured at ILBS. So here basically first line agonists are there and then second line agonists. Usually these 4 agonists are used generally, ADP, epinephrine, collagen, and ristocetin. There are various targets and which measure various functions of the platelets. Now let us see how the hemostasis is balanced. So we can see that hemostasis is balanced in cirrhosis. For example, in primary hemostasis, anti-hemostatic factors are thrombocytopenia, abnormal platelet function, induced production of thromboxane, and others which inhibit primary hemostasis. Whereas on the other hand, elevated levels of von Willebrand factor and low levels of ADAMTSS13, these are pro-hemostatic for the primary hemostasis. Similarly, for the secondary coagulation, low levels of various factors, dysfibrinogemia, are anti-hemostatic, whereas levels of increased levels of factor VIII, low levels of protein C and protein S. We know protein C and protein S are inhibitory, so low levels means that they are pro-homeostatic in this sense. Then there is fibrinolysis. This is also balanced with each other, but this balanced hemostasis is less stable as compared to the healthy subjects, and these patients are susceptible to many factors. For example, AKI, sepsis, ACLF, simple drugs can lead to a tilt to either pro-hemostatic or anti-hemostatic scenario. Now let us see thrombin generation in cirrhosis. What is the role of platelets? So this was the study which showed that when platelets were adjusted to a standard count, that is more than 1 lakh, then the thrombin potential is similar in cirrhosis versus control. All are equal. That means platelets from patients with cirrhosis are suitable to support adequate thrombin generation. But when platelets are not adjusted, that means they reflect the actual thrombocytopenia, then there is a problem. Then there in cirrhotics, the thrombin potential, the potential to generate thrombin is less. So what does it teach us? That low platelets in cirrhosis may be equal to low thrombin generation. So it is not actually the potential, but it is the actuality is low, potential is there. Now, how did we reach at the platelet count of 56,000, which is considered a sine qua non of the cutoff, which was considered initially? So this was again from this study, which showed that median thrombin generation is equal to the healthy subjects if platelet is more than 100, but thrombin generation equal to or higher than the lower limit of normal reference range if platelets are more than 56. So at this level of platelets, the thrombin generation in cirrhotics is above the 95 percentile, that is considered the normal range. So this was the now limitation of thrombin generation assay is that platelet function is not assessed. It is only assessing the concentration, whereas we know that platelet functions may be adequate, or even platelet may be hyperactive, hyperaggregating also. Now this was a study which showed that conventional coagulation tests can be abnormal, but viscoelastic test, ROTEM in this case, can be normal in both ACLF and non-ACLF patients. As we can see, about 90% of the patients in non-ACLF and 66.7% in the ACLF group patient had abnormal PT but normal CT extem, which is reflective of prothrombin time. Similarly, despite having low platelets, normal MCF extem in 75% and 42%. Similarly, with fibrinogen, despite low fibrinogen, there is normal maximum clot firmness on FibTem in very high percentage. So if we rely on conventional coagulation test, then we will be transfusing unnecessarily to these patients. Similarly, in cirrhotics, there is a hypocoagulable ROTEM, but normal or hypercoagulable on thrombin generation assays in stable cirrhosis. So again, ROTEM may be abnormal, but still thrombin generation assays are normal. So even ROTEM can give us information that if we transfuse according to ROTEM, we might be over transfusing again. Okay, so these are the destabilizing factors, and through various mechanisms, acute kidney injury, bacterial infection and sepsis, and ACLF, these three are destabilizing factors and ultimately leads to bleeding, thrombosis, bleeding. So these factors are correctable factors. They may be correctable factors. So if we can defer the procedure till these are corrected, well and good. Otherwise, we can proceed. Now, what should we do prior to invasive procedures? So first, we have to assess what is the bleeding risk. So these are three factors, three group of factors that affect post-procedure bleeding. First is the procedural factor. That means what is the inherent procedural risk. It is classically said that if it is more than 1.5% of the procedure, then it is considered high risk, or if the procedure is such that once bleeding occurs, then there is a imminent life threat to the patients and very difficult to control the bleeding, so it is a high risk procedure. Procedural factors also include operator experience, use of ultrasound imaging. Then there are patient specific factors. For example, patient is on anticoagulants or antiplatelet medications or not. Bacterial infections we have seen, renal dysfunction we have seen, clinically obvious DIC, mucosal bleeds or spontaneous bleeds, are they occurring or not. Severity of liver disease is also very important. Stable cirrhosis, decompensation cirrhosis or ACLF, in that order. Now, these are the Society of Intervention Radiology Guidelines 2019. So, we can see that there is a discrepancy between the intervention radiology guidelines and all the medical society guidelines. So, they won't agree to each other, and that's the confusion going on. So, this guideline indicates that if the procedure risk is low, these are the cutoffs that they have given. INR, low risk position, no need to measure. In platelet count should be more than 20 to go ahead, and fibrinogen more than 100. But whereas in high risk procedures, INR should be less than 2.5, platelet should be more than 30, and fibrinogen more than 100. If these cases are, if these criteria are fulfilled, there is no need for correction, according to SIR 2019. Now, these are the medical society guidelines, EASL, ASLD, AGA, Transfusion Medicine Society guidelines. They say that some societies say don't correct, some even say that there is no need to evaluate even routinely before procedures. Why? Because whether you take conventional coagulation test, ROTEM or TAG, these do not predict accurately the risk of bleeding. Risk of bleeding is determined by the severity of the disease, associated comorbidities, antiplatelets, and so on and so forth. So, the basic question is, even if we find out which patients are at high risk, does giving prophylactic corrections really decrease the risk of bleeding? And is there any benefit of giving them, giving patients who are not bleeding prophylactic these blood product transfusions? So, though many societies indicate that these should not be evaluated routinely, but it may serve as a baseline status. They acknowledge that testing is not indicated to predict post-procedural bleeding, but it serves as a baseline status. If patient starts bleeding, then you can utilize these. Now, let us see, this is an old study, but very important. This was a study on paracentesis procedure. Now, more than 1,000 patients, LVPs were done, and lowest platelet was 19,000 and highest INR was 8.7, and no significant bleeding in any patient. So, that is what we have to remember. Now, patients' bleeding risk increases with INR and platelet. This is a well-known fact. If INR is more than 1.5, hemorrhagic complications are more, and up to 12.5%. Similarly, if less than 50%, then it is high. But pre-procedural transfusions does not mitigate that increased risk. So, in this study, patients received correction FFP before biopsy, and in some patients INR did not get corrected, but in some INR got corrected. And again, if you look at the hemorrhagic complications, they were similar. Similarly, for the platelets, platelet transfused or not transfused, hemorrhagic complications are almost similar. In fact, if platelets are transfused, it seems that it was numerically higher, but not statistically significant. Now, this was a recent study published which showed that whole blood thrombin generation was associated with procedure related bleeding in acute decompensated cirrhotic, not in compensated cirrhosis. This was a very recently published study. 231 patients, 80 compensated, 17 stable decompensated, and 81 acute decompensated. In compensated, 20 procedures done, no bleeding. In stable decompensated, 52 procedures, no bleeding. In 81 acute decompensated, 174 procedures, 11 bleeding and 6 major. Then this studies whole blood thrombin generation with thrombomodulin. And as we can see, pre-procedural thrombomodulin modified thrombin potential less than 350 nanomole per liter per minute. If it is less than they predicted bleeding. So this cutoff had sensitivity of 100%, negative predictive value of 100% for predicting major bleeding. So we are interested in major bleeding only. So this could be one test which has been shown that it could predict independent of the severity of liver disease, but only 6 patients with major bleeding, so conclusions cannot be drawn firmly. Now there have been various studies on TAG versus conventional coagulation test for prophylactic coagulation correction prior to invasive procedures. These were the two studies which showed that TAG group significantly had lower use of any blood products. This was from India and this for USA. Similarly, few studies on ROTEM versus conventional coagulation tests prior to invasive procedure. This was from ILBS pediatric department. So again we showed, as expected, the ROTEM group has significantly lower use of blood products in both the studies. Now this was the thesis of Dr. Tushar which was done. Now this compared two ROTEM cutoffs for transfusion, standard versus relaxed. The standard was what usually is used in liver transplant cases, and relaxed was about 10% relaxation was given to see if we use the relaxed cutoffs whether bleeding increases or any other complications increases. So this was the study design. Adult patients, inherent procedure bleeding risk was assessed. If it was low risk, then we saw if there is any patient specific factors, for example renal dysfunction, sepsis or spontaneous mucosal bleeds. If there is no, then no correction needed, excluded. If patient is high risk procedure or low risk plus any of the high risk patient factors, then we assess. This was the modified SIR guideline in consultation with our IR colleagues. If platelet less than 30, INR more than 2, fibrinogen less than 100, then we randomized standard versus relaxed. The large number of patients, 519 and 514. So ultimately, data for analysis, because procedure cancelled in 6 and 1 patient, so 519 and 524 patients included in each group. So these were the criteria used. For FFP, it was extreme CT, more than 80 or more than 90. Similarly, for cryoprecipitate, according to extreme MCF and 15 MCF, and for platelets also according to these criteria, and for tranexamic acid. So basically, we relax about 10 to 12% of the criteria to see what is happening. So these were the procedures done. These were the two groups of procedures. Inherent high risk procedures with or without high risk patient factor, these were 332, and the another group was inherent low risk with high risk patient factor, 711. So variceal ligation, endotherapy, polypectomy, so on and so forth, paracentesis, thoracocentesis, lymph node biopsy, transjugular liver biopsy, etc. So these were the baseline severity indices. You can see average MELD sodium is quite high, 28 and 27, they are the really sick patients. And many patients fulfilled ACLF criteria according to APASL and also according to the CLIF. So if we look at the blood products transfused, in a standard group it was higher, this was expected because this was the relaxed group. So all the products transfused were less in relaxed ROTEM group, which is expected. But the hemorrhage, major hemorrhage, minor hemorrhage, total non-bleeding complications, and 28-day mortality and 28-day procedure-related bleed mortality was similar. And On multivariate logistic regression, what were the factors associated with procedure-related bleeding? So AKI stage 3 was one of the factors. This was also expected. Serum lactate, an indicator of severity of the liver failure. This was also expected. CTP score again came out as significant factors. Ascites grade 3, again reflective of the severity of the liver disease. And interestingly, we can see that intrinsically low risk procedure with any high risk factor or intrinsically high risk procedure with no high risk factor, they were similar in the association with procedure related bleeding. So we should consider low risk procedures with any high risk patient factors also equivalent to high risk procedure. Now another type of studies are there, restrictive transfusion policy versus ROTEM versus CCT. This was the study in ICU patients who needed central venous catheterization and they were cirrhosis. So look at the restrictive group. They transfused his FFP was if INR was more than 5 and platelets if platelets were less than 25. So we can see 15.8% in the restrictive group, whereas much higher percentage in ROTEM and CCT groups received blood products and complications were similar. So restrictive policy is also there. Another very important study, on-demand platelet transfusion. So this was a study from AIMS which they did. On-demand platelet transfusion versus TEG versus conventional coagulation tests. In this, INR were normal in all patients, but only platelets were deranged. And they were divided into 3 groups, TEG, standard of care, and on-demand. On-demand means no transfusion prior to the procedure. If they bleed, then they will transfuse as needed. We can see platelets less than 20 were there in 7 patients, and in TEG group none, conventional group 4, and on-demand 3. So these were the kind of procedures. You can see percutaneous liver biopsy was the most common procedure. So they were doing percutaneous liver biopsies also with such low platelets. Now we can see that patients receiving peri-procedure platelet transfusion is obviously higher in TEG and SOC group as compared to on-demand. Post-procedure bleeding also similar. And so if you look at the outcomes in patients who have really low platelet count, less than 20,000, which was 7, so no patient experienced any bleeding episode within 20 days of procedure in all the patients who had platelet count less than 20. So this is one protocol which is going on in our department. One of our students is doing up. Here we have divided into 3 groups, high cutoff, low cutoff, versus we have added on-demand group also. Again, in high cutoff and low cutoff, we have decreased by 10 to 15%, and whereas in on-demand, we will transfuse only if bleeding occurs post-procedure, because it is justified now also. So what are the future areas? The question is how to incorporate thrombin generation assays, platelet function assays into peri-procedure protocols. We need to generate more data to incorporate such things into our protocol. To summarize, primary hemostasis, secondary hemostasis, RBCs and activated neutrophils are interlinked. Conventional coagulation tests have their own fallacies. Global viscoelastic tests are increasingly used. Other platelet function tests are there, and they analyze separately different facets of platelet function. There is a balanced hemostasis in cirrhosis. Balanced hemostasis is very precarious and less stable. It is susceptible to many factors, AKI, sepsis, ACLF drugs. There is discordance between IR and medical society guidelines for prophylactic blood transfusion before invasive procedures. So stabilize and correct factors if procedure is not urgent. VET use leads to less prophylactic blood use. These cutoffs for VETs can be relaxed, but how far can it be relaxed? This is a study of, we need more studies. So further RCTs using an on-demand limb for prophylactic blood products use are needed. and how to incorporate thrombin generation assays, platelet function assays into peri-procedure protocols. We need further evidence and studies in this manner. Thank you very much for it.